We are live.
Good evening, everyone. Welcome to this 101st episode of Gyan Pravah podcast series by Fogsi. This is a Fogsi presidential initiative by our visionary president, Dr. Sunita Tandulwadkar, madam. Madam is taken over as the president in January this year, and she has initiated so many projects, series of projects, social as well as educational projects for everybody, for students, for public, and for everybody concerned. So this Gyan Pravah is actually a daily podcast. So at 8 p.m. every day. So every day we have a leader talking to all of us. So this is relayed live to 48,000 gynecologists across the country. And so every day we get insight into a lot of things actually. May not be just obs and gynae, but a lot of other things related to life, to spirituality, and a lot of other things. So it's been a great learning experience for all of us. So introducing Madam Dr. Sunita Tandulwadkar, she's the head of the Obs and Gynae department at Ruby Hall Clinic, Pune. She's a endoscopic surgeon, a very skilled endoscopic surgeon, and she was the president of the IAG, that is the Endoscopy Society of India, the Gynae Endoscopy Society. And as I said, she's been, initiating so many projects all over, since the time she has taken up.
Thank
So,
you.
madam, just for your message.
Thank you. Thank you, Sarita. And namaste, Dr. Partha Basu, sir. It's such a great pleasure that you came on a Foxy platform. Sarita is one of the most sincere, talented, hardworking, passionate, and tremendously knowledgeable in her subject. The way she's working for her oncology committee is commendable. And her, uh, you know, she wants the government to start thinking about 9 to 14 age group single dose. I think the persistently she keep on writing to me, we keep on pressurizing the government. Government always will have their own different issues to tackle, and we don't know why, but we do believe by 2026 they will change it too. And I think Sarita will be the most happy person that time. Having Dr. Partha Basu, I think it will be most important and most knowledgeable podcast. Everyone will enjoy this. Dr. Partha, our series is we have 30 committee chairpersons, so 30 people on 30 day. So on every month on 9th, Sarita comes with one of the faculty. They may be even non-academic, spiritual, philosophical background, or anyone who has done something out of the box, have done the world record, or it may be a politician. We had our central minister also coming on the board. So I think it's not only the committee chairpersons who are working, we are evolving every day. Today is 101. So I met 100 faculty from different fields, and I definitely felt that I got, myself so much into this podcast, it became addictive. What we will be listening today is always a game changer. And the protocol is once we get Sarita introduce you and have welcome to you, I disappear and I join from the viewer link, and you and Sarita will be in the frame. And that 45 minutes will enjoy the dialogue between both of you. So thank you for being on the Proxy platform, and I welcome you here.
Thank you, madam. Thank you so much. So we have Dr. Partha Basu from IARC, that is the International Agency for Research in Cancer, from the division of the WHO, and he's based in France. So he's head of the Early Detection, Prevention and Infections branch at the IARC, and he does his MD in gynecology, a postdoctoral training in gynae oncology, and a PhD in clinical oncology. Before joining IARC in 2015, he was the head of the Department of Gynecological Oncology at the National Cancer Institute in India. Dr. Basu is well known for his research that has informed several guidelines and recommendations from the WHO and other international organizations. He has contributed to several technology development projects such as thermal ablation for cervical precancer, which is such a simple technique, HPV detection technologies, and recently we had a validation of the Indian HPV test, again supported by IARC, AI-supported detection of cervical neoplasia, etc. He has significantly contributed to build capacity in delivering quality assured cervical and breast cancer early detection services in several countries. So he has to travel a lot to do all this. So he's leading the development of guidelines on cervical screening and HPV vaccination for the European Union. And in fact, he's also authored the publication on the single dose vaccine, and which has actually is now introduced in so many countries across the world. Dr. Basu has 306 publications in peer-reviewed journals and more than 10,000 citations. Thank you so much, Dr. Partha, for joining and sparing your valuable time to speak to all of us on this topic today, from a gynae oncologist to he's a global champion for women's cancers. So we will trace this journey and speak to you and get insights and get inspirations from you for how we can actually head towards elimination of cervical cancer in India.
Thank you. It's beautiful, Partha sir, and you should know that this year my two flagship programs is if we want to make India or a Bharat cervical cancer mukt, we have to go on one side about the awareness of the vaccine, and on other side detection, early detection, I should say, with the HPV screening. So we have many projects, Do Tike Jindagi Ke, because in India still it is Do Tike for 9 to 14 age group. We are working with American Cancer Society also with that. And we are sensitizing 50,000 IMA doctors in addition to 10,000 gynecologists. And we have another project of WHO 90-70-90. So Nirmal Banaras Bharat. We have the grant from another donor
Japaigo.
organization. Yes.
Japaigo, yeah.
Japaigo is our implementation
Okay.
partner over
Okay.
there, and it's a BB Foundation who is working very hard with it. And in that, we are working on Nirmal Banaras Bharat is again the Abhiyan, which will detect at least all the women from Banaras will be doing a HPV screening between 35 to 45 age group. And those who are positive, they will be in Tata because Banaras has Tata branch over there. So they will be treated over there. So 20 gynecologists, this is completely with the private sector. 20 gynecologists in their nursing home has come forward for this Nirmal Banaras Abhiyan. And I think government will get attracted towards it, and probably we will be able to run that in many states and probably over the country in time to come. So thank you for your
Thank
all
you. Thank you
advance.
so much, Dr. Sunita, for having me for this program, and Dr. Sarita, my good friend, for conducting this session. Good evening to all the viewers from India. When we talk about any health program like cervical cancer screening or HPV vaccination, two things are most critical. One is access, and number two is quality. So that has been my focus of research over the last 10 years. Now it's going to be almost 11 years. I'm here at IR. As you know, as a gynecologist or every gynecologist who is there in India, we have been seeing day in and day out cases of cancer cervix presenting at stage 3B, stage 4, with complications like fistula and pain. It's a miserable sight. And then especially because we are talking about a cancer that affects women at a relatively young age. And most importantly, this is a cancer that is almost fully preventable. So we have the HPV vaccine on one side. So as you know, when the vaccine was introduced, it was licensed way back in 2008, 2009. The recommendation was to go for 3 doses of the vaccine. And in 2009, my guru, Dr. Shankar Narayan, he started a very important study. That time he was looking at 3 doses versus 2 doses of the vaccine. And essentially, because that time the recommendation was to go for 3 doses, so he was trying to see whether 2 doses would be enough. And then in 2010, when 20,000, almost, the target was to recruit 20,000 girls between 10 to 18 years of age. When almost 90% of the recruitment was completed in 9 different sites in India, the government of India stopped all vaccination in all research projects because of some reported deaths in another project that was ongoing in 2 sites. Now, these deaths had nothing to do with the vaccination. These were deaths like falling in open well, snake bite, insecticide poisoning. But then, whatever it is, the government stopped vaccination in research project. And because of that, we landed up with a situation where some girls received 3 doses of the vaccine, some received 2 doses of the vaccine, and some received a single dose of the vaccine. Just think of it, it is serendipitous. I mean, no ethics committee would have allowed us to evaluate a single dose of the vaccine. But then, great thing about our collaborators in India is that we have been able to retain these cohort of girls. In each cohort, in those cohort, we have more than 4,000 girls. Now they're all women. We have been following them up very systematically over the last 15 years, and hopefully we'll be able to keep them under follow-up for another 5 years. So the Indian study is producing a very important evidence on the efficacy of single dose of HPV vaccine and also durability of this efficacy. Because for for the gynecologists, for those who are making health policies, everybody is asking, okay, single dose is working, but this vaccine is a vaccine that we need to, it has to work for 20 years, 30 years down the line, because it's going to prevent cervical cancer. So from that point of view, the IARC study is probably the most important study globally, and it was very much responsible for the WHO recommendation that came up in 2022 to go for a single dose of HPV vaccine. It does not matter which type of vaccine. It may be the bivalent vaccine, quadrivalent vaccine, nine-valent vaccine. All the vaccines, we have seen the same kind of efficacy of single dose, which is exceeding 90% to prevent persistent HPV-16 and HPV-18 infection. So this is a great, gift from India to the world.
What
And
I
that because of
understand,
this,
sir.
because of
And
this,
unfortunately, India and China has not still taken into those 50 countries who have really adopted. But
let
I'm
us hope
sure
things will change.
the
Hmm.
time will come.
Yeah.
But thank you so much meeting you. And Sarita, you can start your dialogue. And we'll definitely love to meet you in person sometimes.
Yes.
Thank
Thank
you.
you.
Thank you. Thank you, madam. Thank you so much. And thank you for all the guidance.
So, Saita, can I continue or?
Yes, yes, you
Yeah,
can.
yeah. So this has created access to the vaccine, not only in India, but globally. The vaccine is relatively more expensive as compared to the other, vaccines that are used in routine immunization program. But because of this single dose, now we have many low and middle income countries introducing the HPV vaccine, and globally, 68 countries have introduced HPV vaccine or have switched from 2 doses to single dose of HPV vaccine for their adolescent girls. India, I mean, certainly we have again a major development, which is we have the indigenously produced vaccine by Serum Institute, and we evaluated that vaccine, and it is again as good as the other vaccines. So the randomized control trial shows. So again, Indian regulators, they have given the vaccine to be used for the girls as well as for the boys as well. Only thing is that we still do not have a single dose data for the Serum Institute vaccine, but ICMR has initiated the study and hopefully the study results will be available. But very recently, we came up with a guidance which shows what the government can do at the present moment based on the evidence. So how the government can introduce the HPV vaccine in India. So I'm sure the government will be thinking about it, and then our girls will get access to the vaccine, because it is extremely important that the government it comes into the national immunization program. As I said, it is a question of access. It's a question of equity. As long as it is in the private market, yes, some girls will get it, but then that is not going to be effective, because we need, again, high coverage is important. If we are thinking of eliminating cervical cancer, we need to achieve a high coverage of the vaccination. So that's something we need to really uh, go ahead, and that's a priority. And again, Indian research, how it has contributed to the screening area. Again, that's very important. In India, when I have seen many publications coming up and manuscripts I see, but then we really don't quote our own data. I don't know how many of the gynecologists they know that when the HPV test was being evaluated in Europe, in Australia, almost at the same time, we started the study in India as well. In fact, Kolkata, Trivandrum, these two centers were one of the very first centers to evaluate HPV detection technology. And Dr. Shankar Narayanan did a very important randomized controlled trial in Barshi, which showed that a single round of screening with HPV test and then making sure that the HPV positive women are appropriately taken care of can significantly reduce mortality from cervical cancer, as much as 50% reduction in cervical cancer mortality. So again, that's a hugely important evidence that came from India as far as cervical cancer screening is concerned. Yes, of course, there were also studies looking at VIA, which is now the recommended screening test for the government programs in India. But then, again, the government has to think of shifting to HPV detection-based screening, because the current screening program based on VIA, yes, it is something that we should be strengthening further, making sure that women have access to VIA-based screening until the government has enough resources to introduce HPV detection-based screening.
Yeah. Yes, thank you. It's great that India has contributed to so many developments as regards to cervical cancer prevention. And it's high time actually we need to increase the screening and the vaccination all over India. So going back to some questions for you, Partha, is what actually made you take up from shift from gynae oncology, being a gynae oncologist, to the IR?
So, as I said, it was quite a frustrating experience for me, as well as just like any other gynecologist in India, to see these advanced cases. And it was way back in 1997. I was fortunate to get a Commonwealth Fellowship to go to UK and then learn colposcopy at a time when very few people used to focus on cervical cancer prevention. So once I returned to Chittaranjan National Cancer Institute, where I was a gynecological oncologist, and that is when we started evaluating alternative tests for cervical cancer screening. Because that time the standard of care was cytology, which was simply impossible to implement. So we evaluated VIA as a screening test. Then we evaluated HPV detection-based screening, as I said. We evaluated cryotherapy, as a treatment method for cervical precancer. So as I got involved in the research area, I was also focusing more and more on public health. I realized the complexities of doing cervical cancer screening. I mean, cervical cancer screening is very complex in the sense that it's not only you'll have to achieve a high coverage, but then also you'll have to make sure that the positive women are appropriately taken care of. So moving towards research, moving towards public health over the time, and then it was a natural transition for me to an agency like International Agency for Research on Cancer, which is probably the only organization in the world that does cancer research, particularly focusing on cancer prevention and particularly focusing on the issues that are relevant for the low and middle income countries. So that's how I landed up with at IARC 10 years back.
Right. But do you miss, the clinical part, the clinical work? Do you miss operating?
Certainly, you cannot have everything in life, but yes, I definitely miss the interaction with the patients, interaction with the people accompanying the patients, of course, the surgery and then clinics. But then I think the way I'm contributing to not only to global research, but then also to globally the control of cancer, I think that's also a very satisfying experience.
Yes, absolutely. You're reaching out to much more than what you would as a clinician, I guess. So you're reaching into the entire world, actually.
Yeah.
So, Partha, what have you been your challenges and what have been your major achievements at IARC?
So, Sarita, as I said earlier, like my primary focus is to create access and to make sure that people have access to quality assured cancer control program. Now, when I say cancer control program, I'm heading the cancer prevention and cancer early detection branch. And here, of course, we are not only talking about cervical cancer. We have research projects focusing on breast cancer, which is a major problem. Even in India now, the breast cancer is the number one cancer in women, and I hope and I believe that even Fogsi will take up breast cancer early detection among Indian women as one of its key focus areas. So we have been doing projects that are focusing on breast cancer, but also here my area of work is much more wider. In cancer prevention, certainly HPV vaccination is one of my major focus, where we have the project that has, as I said, that led to the WHO recommendation of a single dose and which led to introduction of single dose in 68 different countries. And they are not, all of them are not LMICs. We have countries like Australia, United Kingdom, there's Spain, all these countries in Europe and this thing, they have also they're switching to a single dose of the almost all the countries in Latin America, they have switched to single dose of HPV vaccine. It's a very important message for India. Also,
Right.
we work quite a lot on stomach cancer, gastric cancer. As you know, gastric cancer is a cancer that is again quite a lot. A lot of them are preventable. It is caused by a bacterial infection called H. pylori. So the H. pylori can be detected with a urea breath test and then can be treated if the man or woman is tested positive with the antibiotics. So we have major programs which is looking at H. pylori screen and treat, just like we are talking about cervical cancer screen and treat. So that is so in prevention we have similar kind of projects ongoing. In terms of early detection, we have generated evidence not only on HPV detection tests, but then how to manage the HPV positive women. Say, for example, we have studies that have looked at HPV cells collection, not only vaginal samples, but also urine samples, where we find urine samples are almost as good as vaginal samples or cervical samples. We have large studies ongoing in China, which is generating very important evidence on triage tests using genotypes, using methylation markers. So all these things have contributed to the WHO 2021-2022 guidelines, and currently I am leading the also the guideline development work for European Union. I think that's quite a um, bit of surprise for the European experts here that an Indian is leading the European guideline development work, but that's what it is
I
now.
know. Yes.
And similarly, as we move towards treatment of cervical precancer, we did a large randomized trial to evaluate the thermal ablation device. In fact, the thermal ablation device that is battery operated and developed by Liger, very few people know that essentially that's a product that IARC developed with the small company. And then now it is the most widely used ablative treatment method all over the world. And then we did a randomized control trial, which shows that it is as good as cryotherapy or even loop excision for treating ectocervical lesion. And that has gone into the WHO guideline now. So, so this is the kind of research that we do at IARC, which directly is linked to policies. And once it goes into policy, we also work with the countries to implement those. So one of the major focus of my research currently is to help the guide the countries to implement well-organized cancer screening programs. It can be breast cancer screening programs, cervical cancer screening program, colorectal cancer screening programs. So what I started was a project which is called CanScreen 5, cancer screening in 5 continents. This has been now recognized by IARC as one of our flagship projects, just like our IARC Globocan project. So what we do is we work with the cancer screening program managers in different countries and try to get information on the organization of the screening program, the protocol of screening program, policies, and most important thing, performance of screening program. Because this is very important. And then we put it in one single repository, which we call CanScreen 5. So if anybody searches the website for CanScreen 5, and you'll get that. So this is a single repository where you get information on, say, for example, what is the breast cancer screening protocol in, say, for example, China or in Sri Lanka, or what is the performance of cervical cancer screening program in Sri Lanka. You'll get to know from this particular website. But it's just not passive data collection. There is a very strong component of capacity building. So we work with the cancer screening program managers, we train them, and then we support them to collect data. We create the data collection system, and then also measure how to measure the key performance indicators. So these are the kind of research which I do now and which is very satisfying. As I said, this is very impactful and directly related to the cancer control activities in different countries.
So have any states in India, are they working with the IARC for implementation?
Yes. We have several collaboration in India. We are very fortunate that way to work with several researchers, very well, not only well qualified, but then they're very dedicated, very motivated researchers all over India. Um, uh, we have implementation research studies. That is again one of my major focus. I mean, what is implementation research? I mean, we till now we are all focusing on intervention studies. Say, for example, we have done randomized control trial to evaluate cryotherapy. But when there was a recommendation for using cryotherapy, when countries tried to introduce cryotherapies, then only we realized that cryotherapy has a major challenge in terms of getting the gas supply, in terms of getting those tanks to the primary healthcare. So implementation research looks at all these aspects of implementation. What is the acceptability of the new intervention? What is the affordability of the new intervention? How do you implement that in the real healthcare setting? So this is one of our major focus. This we also call health systems research or implementation research. And we have implementation research studies that are looking at two things. One is looking at the cancer screening pathway. how to improve cancer screening pathway in India. As you know, in India, we have screening for breast cancer, cervical cancer, and oral cancer. And there is another project that is looking at early diagnosis pathway. What is the difference between the two? Screening primarily focuses on asymptomatic, apparently healthy population. On the other hand, early diagnosis takes care of the symptomatic population, those who are presenting to the primary care or to the general practitioners, to the gynecologist with symptoms suggestive of cancer. They need to be, there is no scope for delay among them. They need to be navigated into the pathway so that their diagnosis is confirmed as soon as possible and the treatment is initiated as soon as possible. So so this is another implementation research that we are doing, how to improve the pathway of care for the cases who are presenting with symptoms. And these two studies are going on in different places. So it's in Rajasthan, in Udaipur, in Tamil Nadu, in three different places, and in Kerala also in two different places. And we are all focusing on the rural areas. As you know, the major implementation challenges are in the rural areas.
Yeah, right. So what about breast cancers? What does IARC recommend for in the lower LMICs for breast cancer screening?
So again, as you know, Dr. Shankaran started this randomized control trial in Trivandrum. It's very famously known as Trivandrum trial, which looked at clinical breast examination in women, yeah, by trained nurses or trained healthcare providers. And based on the evidence which shows that there is early detection in terms of the size of the tumor, or when you look at the virulence of the tumor, you detect those cases early. And that leads to the improvement in survival. And 2 years back, we published 14 years follow-up of of that study. So based on the evidence, India as well as many countries around the world, Indonesia, Egypt, Algeria, Morocco, China, these countries, they have introduced a CBE-based screening program. So women between 35 to 60 years of age, they need to go for CBE every 2 to 3 years. That's the um, uh, uh, recommendation. And then, but then, as the countries they are introducing CBE-based programs, we are working with them to evaluate the performance of CBE-based program in real health setting. Say, for
Mm.
example, we evaluated the CBE-based screening program in Morocco, where they screen more than 1 million women every year. So we'll be
Right.
very happy to do the same thing in India, but then we're trying to have conversation with different states. Unfortunately,
Right.
there's a major gap in India. There is no data available. The quality and
Mm.
the availability of data is very poor in Indian states. So that is something would love to work with different Indian states. Another thing in breast cancer is that we are looking at is, the CBE, the false positivity rate is high, what we call positive predictive value. That means out of every 100 woman who is detected to be positive with CBE, only 4 or 5 or even less will have breast cancer. So rest of them will have a false positive diagnosis. How
Mm.
can we reduce that? We are looking
Right.
at a triaging option, just like we do triaging for HPV positive women using cytology or other tests. So we are evaluating a handheld small breast ultrasound. The idea is that we train nurses who are doing CBE or the general practitioners, medical officers who are doing CBE. If the CBE is positive, they will be using that ultrasound on that area of abnormality to identify the obviously benign conditions. Because many of the CBE positive, most of the CBE positive women will have either cystic disease, fibrocystic disease, or will have fibroadenoma. So
Mm.
the idea is if they can, detect those cases and reassure those cases, only the cases that have more severe abnormalities, they will be sent for further evaluation with an expert evaluation, radiology, and if necessary, the tissue diagnosis or cytology diagnosis. So this is again a study we are doing in multiple centers all over the world. In India, we have done it in Kerala. We are evaluating the results, analyzing the results. The results are quite encouraging. And then Indonesia, we are starting in going to start in Egypt. So again, this is a kind of study that will directly lead to policy development.
Yeah, but training the healthcare workers and quality control also. I mean, in the sense that they're doing correctly, that is also a challenge, isn't it?
Yeah.
How do you actually overcome that?
So breast cancer, again, we have to understand, yes, screening is important, but then thinking about complexities of screening and all. But then
Mm.
also we should keep in mind, breast cancer is eminently treatable.
Mm.
Stage 2 breast cancer, you can have 80% survival if properly treated.
Yes.
That is again one of our focus of research. We do patterns of care study, which we'll also call quality of care studies. That means these are prospective hospital-based studies where, I mean, this can be done by any hospital where there is a good record keeping. Prospective hospital-based studies where we recruit breast cancer patients who are registering at the hospital, interview them, try to understand their journey from the symptom onset to getting to the hospital. Try to understand the delays that happen in the pathway of care. Say, for example, what we call pre-diagnostic delay from the symptom onset to going to a first healthcare provider, from the healthcare provider to getting a diagnosis, healthcare provider recommendation to getting a final diagnosis. That's called diagnostic delay. And from getting a diagnosis to going initiating treatment, that's called treatment delay. So these are very important indicators to be measured by the health system. So we don't do that. But these are the things that can be reduced by reducing many of the barriers. So we measure that. And then we get the routine hospital data to understand the quality of care in terms of fulfilling the requirements of the guidelines. I mean, in India, we have our the National Cancer Grid guideline. Of course, there are other guidelines as well to try to see whether the treatment is being given appropriately and whether there is a delay while giving the treatment, whether the patients are completing treatment or not. And then finally, we look for survival after treatment. So this is a whole range of studies which we call patterns of care studies. And this is we are doing on breast cancer patients, but also we are doing for cervical cancer patients. We are doing for pediatric cancer patients because this pediatric cancer is again a very important cancer to be dealt with because most of the cancers are very curable cancers provided the treatment quality is appropriate. So this is again another major area of our research now.
Right. So during Partha, what have been your challenges, in implementation and also in actually doing these studies?
Okay, so when I joined IARC, and then within few years, there was quite a lot of change in structural change at our the way our departments are organized and other things. And then when I became the head of the department, there was a huge expansion plan. The plan was to bring in new perspectives in research. So we decided to go for implementation research. We wanted to go for research that is, as I said, focusing more on quality. These were, as a gynecologist, you can understand. As a routine gynecologist or a gynecological oncologist, these were very new areas for me. And at IARC, we have very little internal funding. For every research we do, we have to get extramural funding. So I had to kind of self-train myself, understand what is implementation research, what are these health systems research, what are the quality indicators that they are in cancer screening, studied the European cancer screening programs in depth to understand how do they implement cancer screening in Europe. And that is how I was successful in applying for new grants, designing new research projects, and ensuring quite a good amount of resources for IARC, and then also to have resources to do the kind of studies that we are doing now.
So, do you expect any challenges with the recent, the US, the Trump administration in your in the research which is
Yes,
ongoing?
of course, we still don't know what will be the final decision of the US administration in terms of IARC. But then, yes, there is a threat. But then we have been preparing for such kind of eventualities for some time, and we are looking for alternative funding. So it's not only United States that is supporting us. Yes, of course, the US is one of our major funding state. The funding coming from the National Cancer Institute is a major source of our research. But then we have also funding from other research, funding organizations like UK MRC, Bill and Melinda Gates, the European Commission in Europe. So yes, there will be some impact. It's just not at IARC. I think if US reduces global research, it will be impacting all kind of research globally.
Right. So, Partha, what about how do you think? Do you think we can actually achieve the goal of cervical cancer elimination in India by 2030? Or
Okay.
when do you think it's going to be realistic?
So the vaccination is the low-hanging fruit. We have to realize
Mm.
this. And that is why, if you see globally, now, if I remember the last statistics, 145 countries they have introduced HPV vaccine. And in India, with the highest burden of cervical cancer, we are still waiting. This is not this is not appropriate. We need to introduce HPV vaccine as soon as possible because the vaccine has become affordable, the doses are available, and then we need to just plan and then introduce the vaccine. I know some of the states are trying of their own, but then it is important for the national government to come up with a very strong support and then a policy for this vaccine. Coming to screening always is a very complex program. Even when you talk about European programs, I mean, it took for them to decades to stabilize, to come to a quality. Well, as far as screening is concerned, we have now HPV detection tests. And at IARC, we evaluated in collaboration with Professor Nija Vatla and their team at AIMS, NICPR, and then two more institutions, four different indigenously developed HPV detection technologies. And this evaluation was using very rigorous criteria, globally accepted criteria for evaluation. And two of the tests, they have been found to be fulfilling those criteria. And these tests are, especially one particular test is available all over India because these were COVID test platforms that were, distributed all over the country in different district hospitals. So this is the time that the government negotiates with the company, makes sure that the test prices are brought down to an affordable range. Obviously, we cannot think of a very impractical price of $1 per test. Technology has its price. But we have to understand, if we have a test that is much more sensitive than VIA, which will lead to ultimately reduction in deaths from cervical cancer. If we have a test that is as objective as HPV detection test, where you can train a lab technician within a few days, and then that's it. And then if the test is so sensitive, we can increase the screening interval. So we don't have to think about every 3 years or 5 years screening. Those who are HPV negative, screen them after 10 years. If she is already 50 plus, Forget about any further screening in these women. So we'll have to be pragmatic, and then we'll have to think about introduction of HPV detection test. So having said that, as I said before, we should not at the same time ignore the already ongoing VIA detection based screening. In fact, we need to strengthen the VIA detection based screening. See, test is just one component of the entire jigsaw puzzle. We'll have to think about organization of screening, which is, I'm sorry to say, is very suboptimal in most of the states. When you say organization of screening, there should be a planned way how to invite the women who are eligible to achieve a high coverage. But most important thing is who are detected to be VIA positive, they should be appropriately managed. And there is the biggest the deficiency in the screening program that is ongoing in India. We are, I mean, I know the states are churning out numbers. They're just saying we have screened so many millions in 2023, 2024. That does not tell us anything. Until and unless we know how many of those screen positives were appropriately managed in terms of either doing colposcopy or in terms of doing treatment. And that is the issue about quality. So quality we will get to understand only when we measure the performance of the screening program. And for measuring performance, there are certain performance indicators. We all know. There is screening coverage, one indicator. The compliance to further assessment is another indicator. Detection rate of CIN2 or worse disease is another indicator. Treatment compliance is another indicator. This is for cervical cancer screening. Same thing is applicable for breast or oral cancer screening. So until and unless we strengthen the organization and quality of cervical cancer screening, it is a wastage of money. So I'm being a little blunt about it, because screening, if done properly, it can save a lot of lives, but then if not done properly, it can cause a lot of harms in terms of individual harm. Because if you are doing a screening test, by say, a woman is examined for VIA by a not so well trained nurse and gives a positive result, so it's a false positive result, and then the woman unnecessarily undergoes further evaluation. But think of the mental trauma. We don't think about the psychological consequence of having a false positive test. So all these things are there. So we need to make sure that the screening program is strengthened. Then only we can think about achieving the elimination targets, which is 90, 70, 90. 70% of the women need to be screened with appropriately at least twice in her life. And then the 90% of the screen detected precancers and cancers are to be treated.
Yeah, treatment is also getting them for treatment is also a challenge, isn't it? That when they are screen positive, the present guidelines recommend that they go to the hospital for treatment. That is where there is a lot of loss of
Yeah,
loss
that's a
to follow.
challenge, but at the same time, there are
Yes.
ways to overcome that challenge. And for that is
Hmm.
why we need an information system
Hmm.
that will record the positive women, and there will be a system where a nurse or a doctor or somebody can call these women. So this system is called recall system.
Hmm.
All the time we have been thinking this recall system is can be done only in the United Kingdom or Sweden. No, see our neighboring country Bangladesh. Bangladesh has used a software called DHIS2 software. This software is freely available, and this is used for managing other health programs like maternal and child health. So they have added a module in that, and they are now registering all the women right at the primary health center to cervical cancer screening pathway. So once the woman is registered, the screening center gets to know that the woman is registered. If a woman is positive in the screening center, the colposcopy center gets to know that these positive women have been referred to our center. So in the colposcopy center, a nurse calls up all the women who have not attended colposcopy within a month, and that is how they are bringing the patients. So why can't we think about what our neighboring country is doing?
Yes. Yes, of course. So how do you think, how do you think the Foxy members can help in this initiative, and how, because Foxy, there are a lot of private
Yeah.
gynecologists also practicing, so not just the governments. How do you think they can
Foxy
help in this?
is a very, very influential organization in India. Not just because there are so many gynecologists who are members, but at the same time, the way Foxy has driven policy in India is really, really remarkable. So I think there are three core areas where Foxy is already contributing, but when it comes to especially cervical cancer elimination, they need to think about. First and foremost is advocacy. There has to be a very strong advocacy from Foxy, not only for the HPV vaccination, but also to make sure that the screening programs are improved across the country. I know that all the Foxy members, they are very motivated to do screening themselves. They do screening, but that will not reach to the women who need it. To reach out to the women in the rural areas, we need to have the program, the national program improved, and then make sure that it is effective. So my request to all the Foxy office bearers will be to really advocate for our women so that they have access to good quality cervical cancer screening and also breast cancer screening. It's very important. So that is number one, advocacy. Number two is building capacity. I know there are a lot of, as Dr. Sunita was talking about, the IMA new program that has taken to educate the IMA members. So similarly, continued capacity building in terms of not only knowledge about HPV vaccine, but at the same time, how to communicate this with the parents. Then in cervical cancer screening, providing the screening services, colposcopy services, treatment services. I know, we have some of the leading figures like Dr. Usha Saraiya, who started way back with inputs in building capacity. We should continue doing that. And then third, this thing is providing service, which all of the Foxy members are doing, but then they can also intensify the screening services. But then as they provide screening services, I would like to again emphasize on the fact that make sure that the screen positive women are appropriately taken care. If you have access to colposcopy, go ahead and do colposcopy and then treat based on the colposcopy diagnosis or biopsy diagnosis. But if you don't have access to colposcopy, you can follow the screen and treat protocol where you can apply acetic acid, see the abnormal area, and then treat either with ablation or with excision.
Right. Yes, absolutely. So, Partha, how can IARC help the Foxy in, making this implementation possible?
So IARC, as you know, we do research not unto research. We do research to drive policies. So that is our most important role. And as we generate evidence, especially evidence from the Indian context, as I said before, I mean, India has generated a huge amount of evidence in cervical cancer prevention, cervical cancer screening, treatment, and then we are really fortunate to have people like Dr. Shankar Narayan, Dr. Professor Nija Vatla, Dr. Usha Saraiya, who have been investing in research right from the beginning. But then it is time that this research is translated into program, and once the program is policy has been taken, the program is implemented properly. So as we'll be very happy to work with all the different state level programs to build capacity of the cancer screening program managers to understand what is quality, how quality can be ensured, and most important thing is how quality can be improved over time. And for that, what we need is that every state invests in health information system, invest in capturing information data on those women undergoing screening, and somebody looks at the data using the key performance indicators. It's just not collecting data will be enough. One has to analyze the data and try to understand what that data means. And that is as I said, the one of our major focus, and we'll be very happy to either collaborate with Foxy and see how we can build capacity in the different states and improve the quality of cancer screening programs, which I strongly believe is very much necessary at this point of time.
Yes, I think we are almost, we just have 5 minutes to go. So is there anything else that you want to say, any message did you want to give to the Foxians?
Um, More than the Foxians in general, I would like to you know uh, talk about a little bit about every clinician investing some time in research. We need to understand without research, things will never improve. I know in India, all the clinicians are extremely busy. They have a huge patient load to manage. But then always, it's not that, always research is randomized control trial designs and other things. There can be a lot of research that can be done with routine data. Routine auditing of our own work is very important. And especially now, all the health facilities, especially the tertiary care centers, where we have a lot of young clinicians, uh, all the tertiary care centers are moving to electronic medical records. And this is a very good opportunity for young clinicians to make sure that the quality of data collection is improved in the routine care. Say, for example, the cancers that are being registered in the hospital, their treatment data, their follow-up data, so that you can do this kind of studies like patterns of care studies. You can look at what is the quality of treatment you are giving to your patients. Where are the delays? Where are the patients, dropping out from the care pathway, not completing treatment? What is the survival? There is very little survival data available from India, unfortunately. Excepting some studies in Tamil Nadu, there is very little survival data. So we can generate a lot of survival data. And lastly, there is now a lot of focus on patient-reported outcome. And one of the most important patient-reported outcome is quality of life. And quality of life studies, again, we are doing, and we are now looking at not only quality of life of the cancer patients when they undergo treatment, but then we are looking at the quality of life of the survivors. A very interesting study we recently completed, where we looked at the quality of life of the breast and cervical cancer patients 1 year after completion of treatment. We expected that there will be a significant improvement, but it didn't
Mm,
happen. And then we tried to see in among those women who are not having that improved quality of life, what was the most important determinant? You'll be
mm,
surprised to know. The most important determinant was the expenditure on treatment, even 1 year after completion of treatment. Of treatment. So we forget about the fact that, say, for example, a breast cancer patient, 1 year after completion of treatment, she has to come again and again to the hospital for checkups. She has to
mm,
continue the hormone therapy, for which she is
mm.
incurring expenditure. And our insurance system does not take care of this kind of expenditure. So this is what we call
Yeah.
financial toxicity. So
Mm.
patients getting, spending more than what they can afford for treatment. And this is an important quality of life is a very important patient reported outcome. And these studies can be done by hospital-based studies. So investing in research is very important in Indian context. And we have the capability. Just the thing is that we need to have that orientation to do more and more clinical research.
You may be happy to know that Dr. Sunita Tandulwadkar has initiated a lot of, data collection across the country. One is called Know Your Number. So every lady that they see, the gynecologist sees, at least record the data, the basic things like weight, height, the blood pressure, the hemoglobin A1C, and because they themselves don't know what are their values. So I think this is important not just for the women to be aware, but also for data, across India, what we can collect. So this is a
Absolutely. And now we
nationwide
have the
audits
unique
which she
ID
has.
number, which through which the data
Yes,
can
the
be
Aadhaar number. Hmm.
linked
Yes,
and is
yes, yes. So these things she has initiated. right from the time she started. So I think there are about 7, 8, surveys which are happening across India. So yes, we've come to it's 9 o'clock, so we need to end this. It's been really wonderful. It's been great speaking to you, Partha, and learning so much from the about the wonderful work that you're doing, and what how we can work. The Foxy can work with you, and actually bring down cervical cancer in our country. Thank you so much once again.
Thank you. Thank you so much, Saita, for having me. Thank you.
Thank you. Thank you. Have a good evening.
You
And
too.
thank you. Yes. Yes. Thank you, Evangel, for providing all the support.